Hello, and we are live. This is Dr. Sarah Merritt with Lifestream Health Center in Bowie, Maryland, where we're working to make pain management caring, accessible, patient-centric, and evidence-based. We are talking to physicians that I know, people in the community, people who serve patients with chronic pain, so we can help educate the public, educate our patients, and help people understand better their own bodies, and particularly if you have a chronic pain condition. I am so excited to have Dr. Celine Lee here today of Lotus Rheumatology and Wellness in Utah. And I would love to have you introduce yourself, Dr. Lee.
Hi, everybody. My name is Celine Lee. I'm a rheumatologist. I practice in around Salt Lake City area in Utah. And I am going to talk about how the regular back pain can be different than one of a rheumatic disorder called Ankylosing Spondylitis. So I'm happy to be here.
Yeah, I'm so excited. So I think it's very common in my clinic for us to get referrals of patients that have significant pain in the back, in the low back in particular. And I think that's where it becomes important to understand what are the different potential causes of that. And certainly this condition, ankylosing spondylitis, is one of them.
Exactly.
Sorry. So let's talk a little bit about that. And I'm also interested to kind of maybe even talk about, what is a rheumatologist, and why might somebody want to see that type of doctor?
Yes. So to answer the second question first, so rheumatology is a lot of time that I get referral about what you would get referral for, like joint pain or back pain, things like that. Mm-hmm. In rheumatology, we don't treat the regular, aches and pains, but we are more focusing on autoimmune disorders where the joint pain and stiffness and back pain is caused by inflammatory disease. Instead of just wear and tear and degenerative diseases. So I'm pretty sure that Dr. Merritt, you see a lot of patients with back pain, knee pain, shoulder pain, and some of that could be a rheumatic disorder, such as if the knee pain is a little bit different, it is in the young people without any trauma history, suddenly the knee got swelled up, and those patients need to get evaluation for potential rheumatic disorder. So I see a lot of those patients. And the disease that I'm going to talk about, ankylosing spondylitis, it's one of the disease that I see often where patients get confused. I have a back pain. I saw the back doctor, but I'm only like 18 years old. Why do I feel like I'm 90 years old? I'm only like 18 or 19. So a lot of people get very confused about why this back pain occurs in such a young age. And
and there's some specific symptoms they might be talking about in these types of patients. What would be a typical description of symptoms for that type of patient?
Yes. So as I said, the first one is the age. So the onset of the disease, usually in the young patients. So I see a lot of patients who develop the first symptoms in their late teens. So like 16, 17 years old. A lot of people will develop the symptom in 20s or even 30s, but majority of the people will develop the symptoms before age 40 to 45, to the point that if it's occur after age 45, that we usually don't consider ankylosing spondylitis because this disease usually occurs in the younger patients. So if we see patients who have back pain in a much younger age, then we need to think about, maybe it's something rheumatologic disorder rather than just mechanical back pain. Obviously, if the patient have any trauma history, such as car accident or any trauma, sports injury, then that back pain could be related to the sports injury or trauma. But if the young person have a back pain, chronic, it occurs every day without any history of trauma or injury, and then we need to consider could it be rheumatic disorder such as ankylosing spondylitis. So that's the first point. And I kind of make like 5 points how they're different, between mechanical back pain and ankylosing spondylitis. So first is the age that we just talked about. And the second one is the time of the day when the pain is most severe.
Yes.
So, yes, everybody, I get back pain after I shovel the snow, rake
Mhm.
the yard. I get back pain, and I'm pretty sure you get back pain too, Dr. Merritt. So it is common that when we do some manual work and we kind of use our body more than we usually do, then we'll get this back pain, and those are usually mechanical back pain. But in ankylosing spondylitis, very interestingly, the time of the day where the back pain is the most severe is early morning, like 5
Okay.
a.m., 6 a.m.
Wow.
Yeah, the
So
patient
might
was
wake
just,
somebody up at 5 or 6 a.m.
yeah, some people can actually wake up in early in the morning because of the back pain, because the pain is most intense in the early morning. So they would typically feel like when they wake up, they feel a lot of back pain, very stiff, and then they try to get up and they cannot get up because they feel so stiff, and they'll have to shuffle around a little bit because the pain is quite intense in the early morning, even though they didn't do anything, during the night, they just slept. So, their spine was not exercised. So it
Yeah.
was resting for like 7 or 8 hours. But the pain is most intense, and that's what's the difference, from mechanical back pain, because mechanical back pain will be worse after we do a lot of activities. But
Mhm.
in ankylosing spondylitis, it's the opposite, where the pain is most severe after a long time of resting, such as after waking up in the morning, a long hour of sleeping, then the pain will be most intense. So this is I mingled the second and third point together, because
Yeah.
the third one was the relationship with the physical activities. So as I told you, usually in the afternoon, after physical activities, after shoveling the snow, raking the yard, doing a lot of manual work, then mechanical back pain can occur because of the muscle spasm or some arthritis, degenerative arthritis in the spine. Then after those physical activities, the back pain get worse. But in AS, in ankylosing spondylitis, when they're resting, the pain is more severe. So that's the third point that we kind of talk together.
Yeah. So they almost have more problems if they stop. They're better if they keep going. And
Exactly. Yeah. So to the point that in younger patients, we sometimes see those younger patients who have ankylosing spondylitis. They want to just continuously move around. So they usually cannot stay still, because if they're sitting on the desk and just working on the desk for long hours, their back pain will be more severe. So they would want to move around intentionally or maybe subconsciously, so that they can have less back pain, because the pain gets worse when they're sitting down still and not move their body. So they want to move around continuously.
yeah. And do
Mhm.
patients do you tend to have to ask about that, or is that something that patients will often be telling you as they describe their day and how they feel?
So some patients will say that first, even though I don't ask particularly about that point about relationship, the time of the day, or relationship with the physical activities. But some patients, it is so they've been living like this for so long time, they sometimes forget to mention that they tend to move around constantly because of the pain gets worse with immobility. Then I ask, by the way, do you feel you need to move constantly, because otherwise you feel very comfortable and feel stiff, and the pain will get worse, and do you tend to move around? And they say, oh yeah, I have the standing desk because I cannot sit still. They'll move around. Then they'll tell me the story. But sometimes it's like become like the way of life. They become habit. So
Yeah.
sometimes they forget to mention it because they do it almost automatically. So asking this question will be able to elicit the key information. They can make the diagnosis.
Good.
Yeah. And the fourth one, and I'll talk about the nature of the pain. Again, the stiffness. So
Goodness.
the pain and stiffness can be, they can usually come together,
Mhm.
but people can have just stiffness without too much of pain. If their pain tolerance is pretty high, they'll say just, oh, I feel very stiff and I need to move around my body for a long time to be able to move more smoothly. And typically, this stiffness is worse in the morning, so we call it morning stiffness.
Mhm.
Yeah. So they
Mhm.
wake up, and then
Yep.
They just kind of, they cannot just get up and go. They need to kind of move their body a little bit, and they need to do some stretching. And typically, this morning stiffness will last for more than 1 hour. Or longer than usual. Most people, even my age, I'm in mid-40s. After you wake up, it's a little bit stiff, and
Yep.
after about like 3 minutes, 4 minutes, I move around and it's gone.
Mhm.
But in ankle spondylitis, even young people like 19 years old, they'll have to move, like to stretch their body for 1 hour to be able to feel comfortable. Some
Mhm.
people it can be 30 minutes. So there's some people it's all day. But it'll be usually 1 hour is a good kind of time. But there's a little bit of some people a little bit shorter, some people a little bit longer. But the thing is, it's usually much longer than what usual people would feel with just mechanical back pain.
Okay.
So that's also important thing. And
Mhm.
other one is in the morning, the locational pain can be a little bit different than just the lower back pain. And lower back pain is most common, but some people can feel the pain in the buttock area. So
Okay.
some might say that, oh, it's not my back, it's on my butt area. And
Mhm.
I just brought this. I'm pretty sure that you have this in your
Oh, yeah.
clinic.
Yeah, we have those
Yeah.
models. Yep.
So that's the SI joint here. So this is a sacrum and this is ilium. This
Mhm.
is sacroiliac joint called SI joint. And this joint is the one that ankle spondylitis start the inflammation first. And when
Mhm.
you look at here, so it's right here. So when you look at it, it's a little bit lower in the back. So
Mhm.
it's in the butt. So some people will say that I have butt pain. And some
Oh,
people
yeah.
say it alternates in different
Mhm.
side. There's sometimes it's the right side, sometimes the left side, sometimes it's both. But they will say that I have some buttock pain, and sometimes that's the early symptom of ankle spondylitis because ankle spondylitis usually causes inflammation in this SI joint, and then it'll be felt as buttock pain and not necessarily the lower back pain. So that's another one that is different than mechanical back pain.
Mhm.
Um, but having said that, as you know, the SI joint can have degenerative joint disorder. So in older patients, they can have buttock pain because of the SI joint arthritis, but that's more degenerative and it's not inflammatory. So there's a little bit different. So young people have a buttock pain with morning stiffness, then ankle spondylitis need to be considered.
Okay.
And that leads our fifth, the last point,
Mhm.
and that is dramatic response to NSAID. So NSAID is NSAID, as you know, Dr.
Yep.
Barrett. So
Non-steroidal anti-inflammatories. That's right.
exactly, it's not steroidal anti-inflammatory drug. So it's anti-inflammatory drug, but not steroid. So ibuprofen, Advil, that's ibuprofen. It's the most common that people know. Aleve, which is naproxen, and there's also meloxicam, Celebrex, and indomethacin. There's a lot of different type of NSAID, but they are all the same category of NSAID. And ankle spondylitis tend to have dramatic response to NSAID, which can be different than mechanical back pain. So mechanical back pain, a lot of time it comes from muscle spasm. So people will feel better, after shoveling the snow, people will do some heating pad, they can do some sauna, they can take
Mhm.
hot bath. So usually those kind of heating and those can helpful. Tylenol and ibuprofen can be taken and they can also relieve the pain. But they can all help the pain, but it's not like NSAID is dramatically better than the other modality. They all can help a little bit to
Yeah.
improve the mechanical pain. And then obviously the physical therapy
Yeah.
and those are important. But in ankylosing spondylitis, NSAID has dramatic response to
Okay.
the point that it's night and day sometimes. If one NSAID works pretty well for the patients, but
Mhm.
they will say, oh, it's night and day different. And
Mhm.
I feel so much better with just taking ibuprofen 800 milligram. I can now move. So
Yeah.
that dramatic response to NSAID is so characteristic. And the reason is in ankylosing spondylitis, the back pain is not coming from mechanical degeneration or muscle spasm. It
Right.
is coming from inflammation of the spine. That's
Mhm.
the reason why anti-inflammatory medications such as NSAID have dramatic effect.
Mhm.
So that's another thing to the point that we sometimes use this to make the diagnosis and how well the patient back pain responds to NSAID.
Yes.
Okay? Yeah, so that's 5.
So age of onset.
Time of the day where the pain is most severe, which is the morning. Relation with the physical activity, so resting and immobility make the pain worse. And nature of the pain, which is the stiffness and morning stiffness that lasts for longer than 1 hour. And the location of the pain, which is the SI joint area and the buttock area. And 5th is the dramatic response to NSAID. So those 5 points, that's the how ankylosing spondylitis is different than usual mechanical back pain that most people will have at some point in their life because of regular degeneration.
Okay, I just put some of those in our chat here, so we're gonna show that for a moment, that the 5 criteria here. So that's great. Yeah, so kind of those 5 characteristics. Well, and I would share a story. I have a patient that I've seen ongoing more around chronic headaches, but she at times has had other areas of pain too, of course. It's very common, in fact, if someone has a significant chronic pain condition, for them to have more than one chronic pain condition. So in my practice, it's very common to see somebody that has more than one significant issue. So for this patient that has significant migraines, she was actually diagnosed with ankylosing spondylitis, and some of her manifestation has actually been in her feet. And that was newer for me. I don't know if that's uncommon. Is that something that happens from time to time?
Yes, yeah, it can happen because ankylosing spondylitis can cause the Achilles tendonitis. So people can have, so usually ankle spondylitis is an axial joint involvement. So they tend to have more of the spine pain. Yeah. But there are some people can have some other joint involved, such as hip joints are very commonly involved in ankylosing spondylitis, and also tendonitis, and Achilles tendonitis is very common in ankylosing spondylitis. So they'll have foot pain, and the foot pain will be located in the kind of the backside of the heel area where Achilles tendon inserts to the heel bone. And that area is called emphysis, where the tendon inserts the bone, and that area tends to be targeted by inflammation in ankylosing spondylitis.
Okay.
Yes, and also some people can have other associated conditions such as eye inflammation called uveitis. So they can sometimes have eye pain. So if the young person who have back pain also have red and painful eye, that person will need to be seen by ophthalmologist, because that person can have eye inflammation, because ankylosing spondylitis, one of the symptoms is eye inflammation as well. So it is important to see if the patient have other areas of the problem. And I usually also ask of the skin problems. I used to be a dermatologist, so skin will be always, on my mind about evaluating these rheumatologic patients, because a lot of rheumatologic diseases have skin condition, rheumatic skin disorders. But in ankylosing spondylitis, if it is associated with underlying psoriasis, then people can have psoriasis. So I usually look at the scalp, in the ear, in the belly button, in the weird areas.
All over.
Yeah, nail. And if the patient have psoriasis, then we know that this musculoskeletal symptom is actually part of that underlying condition. Also, sometimes people can have GI symptoms, such as they can have chronic diarrhea or belly pain, and that person could have Crohn's disease or ulcerative colitis, because that disease also can cause musculoskeletal symptoms of spine inflammation. And
I think that's really interesting, because we're really seeing a lot of co-occurrence. There's really a big co-occurrence, I think, of chronic pain for people who have inflammatory bowel disease. And I think we're just starting to understand some of these connections. And right, it has to do with the inflammation, right?
Exactly. Yes. So, and that's kind of how I know that you approach your patients, Dr. Merritt, and how I approach my patient. That when I look at the problem of the patient, I try to look at the root cause of the condition instead
Yes.
of those of back pain. So even though the patient came to me because of back pain, I'll ask about how's your stomach? How do you
Yeah.
have any rash? How is
Yes.
your vision? Do you have any problem in your seeing things? So I'll ask some other questions because these disorders are systemic, so they can have other organ involvement. The patient may not tell me if I don't ask them first, because they might think that, oh, it's a rash problem, I'll need to see a dermatologist, but
Mhm.
actually it's a part of their
Yes.
rheumatoid
Primary
condition. So
disease. Yeah. Yeah.
mhm,
That's right.
yeah, so
Yeah, and I think that's
that's
like the
important.
importance too of seeing a rheumatologist for a workup and rule in or rule out of certain conditions like this, right? Because very many of them may have multi-system manifestations of these certain types of inflammation. So in those patients where we have some suspicion for something like ankylosing spondylitis, and in my practice, what it looks like is usually we'll order like some cursory labs just to kind of, sometimes it's even to motivate them to see the rheumatologist and make that referral.
Yeah.
Like this isn't going to be enough, but often, hey, here's a little preview, and then see the rheumatologist for maybe a deeper dive or a more
Yeah, that's
tailored
so
dive.
useful. Yeah, because even like checking like inflammatory markers such
Yeah,
as
said right.
ESR,
Mhm.
CRP, yeah.
Yep,
So those markers, if they're elevated, then definitely, the
that's a
person
clue.
should see a rheumatologist, because they can be from the underlying rheumatic condition. And also sometimes some people have family history. So these
Right.
disorders of ankle spondylitis, it is associated with HLA B27 gene mutation. So sometimes they'll have some family member who have that gene mutation, and they, oh yeah, my cousin also have some
Mhm,
back pain, and she was diagnosed with psoriasis. So they could
mhm,
have some family history of similar disorders
mhm.
because of that genetic correlation. So that's another kind of clue that tells us if this is just regular mechanical pain, or is it ankle spondylitis or other associated diseases. So that's also very important.
Here's another like interesting case thought, or another little interesting twist maybe on this diagnosis too, if we're going to like take a little dive into AS. I can think of probably two patients in my practice. So I have a concentration of patients in my practice, I would say, who have something called Ehlers-Danlos syndrome or
Mhm.
hypermobility. And as Dr. Lee knows, it's a condition of, you know, often soft tissue hypermobility and joint hypermobility, and it can be painful. And so we help
Mhm.
patients learn to manage symptoms and learn to, oftentimes a lot of self-care really to get people feeling better. But a
Mhm.
couple of these patients actually have, in addition to this soft tissue diagnosis, I have two that have ankylosing spondylitis. And so it's kind
Oh,
of an interesting juxtaposition of this AS diagnosis that has to do maybe with some um, right? I mean, it's in AS, there might be inflammation in the spine, and there might even be bone formation, additional bones formation in the spine. Is that right?
yes. So when AS progresses, then it can cause more additional bone formation that can connect the vertebra, from
Mhm.
lower vertebra to upper vertebra. It's called
Yeah.
syndesmophyte. So
Mhm.
you can actually see in the X-ray and the MRI that there's a little like bone spur going upward and
Mhm.
connecting the spine. So if a patient who have Ehlers-Danlos syndrome develop AS, that person before developing AS, the person can do a lot of really flexible things. So a lot of
Mhm.
people who have EDS, they can touch the floor with their whole
Yes.
palm without bending their knees because
Yeah.
their lumbar spine is so hypermobile. But
Mhm.
once they develop AS, they will not be able to do that because of the pain and stiffness in the SI joint and lower back, and they'll lose their flexibility from EDS because of the stiffness from AS. So
Yes.
yeah.
And sometimes that makes like a diagnostic challenge too, where somebody, has hypermobility, but it's masked somehow by another condition. I know for some of those patients through their lifespan, their hypermobility
Yes.
vary as we age, we all may lose some flexibility as just part of that process too, I suppose.
Yes, yes. And those cases, it can be difficult to diagnose because they will not have typical EDS and they will not have typical AS. So we'll have to look at the whole picture in the context of, what's going on with the patient and other symptoms associated symptoms and family history and blood tests and things like that.
Yeah.
Mm-hmm.
Yeah, that's great. That's super interesting. What else do we need to know about AS? We really haven't talked about treatment. We sort of talked about what this is and how it looks and how we come to understand it. But, for my patients that have AS, I really don't prescribe the specific treatments. Those are things that are usually done with a board certified rheumatologist. And so that's where we want patients getting those targeted treatment. But I know there are infusions and other medications that people can take for this. So tell us more.
Yes, yeah, that's correct. So initially, back in the days before biologics were invented, so first biologics was invented in 1998 with Enbrel. Prior to that, AS was primarily treated with NSAID. A lot of time they would take indomethacin, which is pretty strong anti-inflammatory, but unfortunately can cause a lot of pain in the stomach, sometimes ulcer in the stomach, and also if you take it for a long time, it can damage the kidney. And there's still controversial, discussions about. We still don't know exactly if NSAID can be considered as a DMARD, which is disease-modifying anti-rheumatic drug, which is the drug that can stop the progression of the disease. And there's still discussion about NSAID can be considered a DMARD in treatment of AS. Okay. A lot of rheumatologists would think the biologics are more DMARD. It can have a better chance of stopping disorder compared to NSAID. So I personally saw a patient who is in his mid-70s. He was diagnosed with AS in his 20s. Took NSAID entire life until until 70, and fortunately did not develop any kidney damage from it. But he developed bamboo spine, so his spine was completely fused, despite the fact that he has been taking NSAID for decades, like more than 3 to 4 decades. He still developed completely fusion of the spine to the point that he cannot expand his rib cage large enough because his thoracic spine is all fused. So his rib cage does not expand as much as it should, to the point that he developed restrictive lung disease because the fact the rib cage cannot expand. And this is despite the fact that he took NSAID for entire life. And more rheumatologists believe that NSAID is not as effective as a DMARD compared to biologics. Yes. So now we have these better medications. So most rheumatologists would use biologics to treat ankylosing spondylitis. So what biologic means? It's a biologic DMARD, such as a lot of people probably saw commercials on the TV, like Humira, Enbrel, Remicade, Cosentyx, those, or Rinvoq, those medications. And Rinvoq is technically not a biologics, but those like more targeted advanced medications, and those medications are believed to be more effective in stopping the disease progression, so that the patient does not have that long-term complications such as complete fusion of the spine. And yes, so the study showed that although there are other medications such as methotrexate or sulfasalazine that is used to treat rheumatoid arthritis, and those medications are DMARD for rheumatoid arthritis, the study showed that those medications are not as effective in treating the spine inflammation. So once the inflammation involves the spine, then we usually need to consider using those biologics.
Got it.
And there are
with the foot, like she really needs it just to be able to walk. It's really about like her functionality with this foot right now is really affected by her infusions.
Yes. So if she had Achilles tendonitis, Achilles tendonitis also tend to respond better to biologics compared to like methotrexate, for example. So she may be getting infliximab infusion. And that should definitely help her Achilles tendonitis. So when a patient who have AS, they have axial, the spine joint involvement, they have some those tendonitis, then we would usually use for those biologics. And according to the patient's other conditions, patient other past medical history, or patients, their family history or other blood test, then the rheumatologist will determine which one is the best medication for that particular patient, because there are about quite a few different mechanisms of action that we can use for ankylosing spondylitis. There's something called TNF alpha inhibitors, interleukin 17 inhibitor, interleukin 23 inhibitor, and JAK inhibitor. So there are a couple of different mechanisms of action how these medications work, and which one is the most best for the patient will be determined by the rheumatologist according to all other factors considered, the patient other symptoms and patient's family history, or like blood test result, what part is more involved, all of this clinical information will kind of give us more like information and guide the rheumatologist to make the decision which medication will have most likelihood to bring remission to that particular patient.
There's a lot of complexity, really. I mean, I think there's just a lot of vocabulary and that specific knowledge, right, of the specific inhibitor, like you were saying, to manage any one patient. It's really a lot.
Yes, yeah, and it's really it's good that we have a lot of choices, because before even like there was not many, and the people who took the NSAID for decades, they still develop bamboo spine, which really severely restrict their daily life, because they cannot turn their head, they cannot drive sometimes because they cannot lift their head up.
Lifespan with the lung disease,
exactly. So and that was not too long ago. That was only about 30 something years ago. So now we have such a lot of choices that can really impact the patient life and really improve their quality of life, and also prevent the future complications. So it's a really exciting time to be a rheumatologist right now.
Yes, it is.
And I also want to mention one thing, and because of this technology, there's more better medications these days. I personally don't use the term ankylosing spondylitis as much as I used to. And I usually I would use that terminology, for my prescriptions, and to talk with the insurance companies.
It might be needed on the insurance end. Yeah, how would you use it with patients?
Axial spondyloarthritis, that's how I usually call it, because ankylosing spondylitis, ankylosing means fusioning, so it means fusion. Spondylitis means inflammation of spine. So spondy is like spine, and itis means inflammation. So spondylitis means inflammation of the spine, and ankylosing means it's fusioning. And before, when this term was coined, many decades ago, people will have fusion of the spine at that time, and that's what's called ankylosing spondylitis. But these days, with the early treatment and proper treatment, the whole purpose of treating this disorder is to stop the fusion of the spine.
Yeah.
So, I kind of feel,
we're not averse to that.
I am treating this patient to, prevent the fusion of the spine. So it's really not ankylosing anymore, because I'm treating before the fusion starts. So
I appreciate that, because in fact, even as a physician, I do see I see this, and in fact, that newer diagnosis called non-radiographic axial spondyloarthropathy. Well, what is that? Oh, well, it's AS kind of without the
exactly. It's like earlier phase of AS. It's kind of more in the spectrum. So if we caught the patient early, it'll be non-radiographic, because meaning that X-ray is normal, but the patient have AS, and that's the timing that we want to catch the diagnosis and
make a big difference.
Exactly. Yeah. So I personally use axial spondyloarthritis more often, and I think more modern, the trend is using this diagnosis more, because we rarely see that I mean, if we see a patient who have this condition, ideally the patient should be seen by the rheumatologist
Yes.
before this permanent ankylosis happens,
Yes.
and therefore it will be not ankylosing anymore. So we call that just axial spondyloarthritis, meaning that the axial joints with the axis of the body is
Yes.
involved. The axial spondyloarthritis, that's more like modern terminology of calling AS.
Yeah, I'm going to give this a hashtag words matter because
Exactly.
what we call this, it actually
Words.
matters, words matter, that we get it
Yes.
right and we talk about things appropriately. And honestly, like it conveys, I think, a little better hope to patients too, right?
Yes. Yes. It's
This is what the
depressing.
condition is. This is what we're managing. This is what we're doing. I get it.
Exactly. Yeah. It's very depressing to hear that word ankylosing because and because they can really severely restrict the range of motion. And, if the person will not develop ankylosis with the proper treatment, the terminology should change because that terminology is pretty old. That was coined before the era of biologics.
Well, Dr. Lee, thank you so much. I'm going to wrap us up. But I really appreciate this conversation. I am so excited to hear all of this and to kind of end with this idea that our words matter around certain diagnoses and pain management, because that's really like huge in how I think about things and how I try to talk to my patients, so we have the right words for what we do. It's a big deal. It's a bigger deal than maybe a lot of folks give it credit for. So I'm so excited to have you. And I love it that you said it's an exciting time to be a rheumatologist, because if I were looking for a rheumatologist, I would want to see a rheumatologist who is excited about being a rheumatologist like you. So thank you. That's so wonderful. Can you tell us a little about how people can get in touch with you in your practice?
I'm located in, to be specific, it's Murray, Utah. It's a city near Salt Lake City area. And then we have a website, which is www.lotusrheumatology.com. Lotus, like the flower of the pond, which blooms very beautifully, despite the fact that it have a lot of murky water around it. Despite the fact that there's some difficulties for the flower blooms anyway, and it thrives despite the fact that it's murky water. And in my mind, the murky water is autoimmune disorder, and the flower, the lotus, is my patient. And I made my logo so that a hand is holding the lotus flower because I want to be that hand. So that's the meaning of the logo. So it is lotusrheumatology.com. And in the website, there's a link to my Facebook page and my YouTube channel, where I sometimes, if I have some education point that I want to tell people, that I will make some posting and videos on my YouTube channel. So you can find me over there as well.
That's awesome. Yeah, thank you so much, Dr. Lee. Dr. Celine Lee, Lotus Rheumatology. And I'm Dr. Sarah Merritt at Lifestream Health Center. Thanks for joining us for this live, and really started our conversation talking about AS, but now we're going to use that to abbreviate for axial spondyloarthritis. Thank you so much.
Thank you so much, Dr. Merritt.
Take care.
Bye-bye.